You've tuned into the podcast Tangible Medical Education. I am your host, Mihайло Винницький of Kyiv-Mohyla Academy. In this podcast, we'll talk about medical education in a very broad sense, its institutionalization in Ukraine and in the world, and about the medical profession more generally. We'll try to highlight the intangible, which in reality makes medicine very tangible and practical. My guest today is Rенато Ґалеацці, who is a Swiss colleague of ours. And I'd actually like to start off, Renato, with first of all, welcoming you, and secondly, asking why the interest in Ukraine, except for the fact that I've heard that you're a very big fan of Pirogov.
Hi, it's nice to see you and nice to be here, actually. I'm very honored to be your host today. I'm interested in Ukraine because the Swiss Department of Cooperation and Development has a project in Ukraine about the reform of medical education. And this interest has not started in Ukraine for me, but in Central Asia, where in the Tajikistan, Kyrgyzstan, Uzbekistan, the Swiss Department of Cooperation and Development was also interested in changing the medical education from the post-Soviet and Soviet time to a modern, what we call modern medical education.
What does that mean when you say modern education? Because I mean, we need to define some terms here.
Okay. The first thing is modern education. It is an education that is not centered on knowledge, but it has three different aims. One aim is knowledge, the next is skills, and the third is attitude. And the second thing that is modern is it is primarily centered on general medicine and on primary health care, which should be in the hands of family doctors and general practitioners, and on the cooperation of primary health care with the specialists mainly working in hospitals. I think these two things are very important in modern medical education.
Okay, so we'll talk today about how we integrate university clinics and hospitals with medical education. And we'll also talk about something that I think is very important. We've talked about this in many podcasts previously about the idea of competencies, which includes obviously knowledge, skills, and attitudes. Let's before we get to that, you mentioned Central Asia. You've traveled quite a few times to Ukraine. You have an interest in medical education and in our region, if you like. But there's certainly very, very large differences between Tajikistan and Ukraine, I would think.
It is a huge difference. The one difference first is the size. Tajikistan has one medical university. I think Ukraine has 21 or 22 medical universities. The other thing is the history. The history of Tajikistan in terms of as we live, as you live, is very short. It started in the 20s of last century. But your history is much longer. It has a much longer development. And the other thing is, I think, and I'm very keen to say that, I think Ukrainians are much more active. They are much more prone really to change something, really to build up a new understanding of medicine, a new understanding of politics, a new understanding of education. And that, I think, is very different. However, there are not only differences.
Well, it's interesting that you say that because the feeling in Ukraine, of course, is particularly when it comes to healthcare reform and specifically in medical education, is that somehow we have lots of vested interests and things are not changing fast enough, and that we actually, in fact, don't really have much of a desire for reform. And you're saying that quite the opposite, that Ukrainians are really sort of change agents.
I didn't compare you with Western countries. I compared you with Tajikistan. Okay. That's the difference. Okay. There are similarities. And one is that even in Ukraine, the reform is very slow. And the reasons, I think, are the same. The reasons are the same as in Tajikistan. It is that the government has too much to say. Everything is done top down. First, you have a law, and then you do something. However, especially when you have reforms, it should be start bottom up. People who do the things have to change. They have to have the will and the impetus to change the things. And that's also, I have found in Ukraine, you have a lot of old-minded people who stay. We have to change first the law and then we change how it is done. But you have a lot of people, and I noticed that in Kiev, in Lviv and elsewhere, that you have a lot of people who really have a impetus to change and to start projects and to start pilots and want to really to implement new things. You know, in Tajikistan, when I said, why don't we do a pilot? Then the vice minister of health said, I am not allowed to make mistakes. I mean, you cannot change anything if you are not allowed to make mistakes.
Well, of course, yes, of course.
That's clear. And I think that's different in Ukraine. You have an experimental side.
Okay, let's talk about a little bit about the experimental site that we have in Ukraine. You obviously, you speak Russian, so it means that you have some understanding of sort of in the inside of our country and have been able to communicate. My understanding is that you don't speak Ukrainian yet, but we will try to impact that in a little while.
Okay.
Let's talk about your interests in the past in medical education. You were not originally a doctor, is that my understanding? Yeah.
No, I was originally a doctor, but during the gymnasium, I made an 8-year gymnasium. I studied a lot of languages. Mm-hmm. I wanted to study literature and German and Roman languages. But then I read Freud, a short introduction in psychoanalysis. And in order to become a psychoanalyst in Switzerland, you have to study medicine. So I started to be interested in medicine, and I started my study with medicine and with natural sciences and with physiology and pathophysiology, anatomy and all these things. And whatever I studied, it interested me. So at the end of my studies, I thought I have to become a general medical doctor. So I started my post-university specialty training to become a specialist in general medicine. And I think that's a very important specialty, which was lacking in the Soviet time. Primary health care was not something that the doctors were doing. They were the feldsers and the midwives, akuszerki. They did the primary health care. And they had a very important task, which was the triage. They had, actually, that Pirogov invented the triage in 1853. So it is a very Slavic invention, the triage. And that's the most important thing. The primary healthcare physician has to make the triage, and he has to know where his competencies end. And this is a specialty that's not non-specialized. You have to learn to do triage. You have to learn where your borders are of knowledge. You have to learn how to cooperate with the specialists. And I think that's the interesting thing in general medicine, the C's. The first contact, the comprehensive medical service delivery, the cooperation, and to be competent in communication with the patient. That's a specialty. That's not just, you didn't get the specialty. You have to specialize in all these different aspects of general medicine in order to become a primary healthcare physician.
Is it possible to know as much as you would want to know? I'm thinking from the perspective of a patient. I'm coming to a doctor who is supposed to be a general practitioner, meaning someone that he's a generalist, as you say. But it's very difficult for that doctor to be knowledgeable in absolutely everything that might be wrong with the patient.
Therefore, I said the important thing is not to know everything. The important thing is to know as much as possible and to know where your competencies end. Mm-hmm. That's a very important attitude and also knowledge that you have about yourself.
We're coming back to the concept of attitudes. By the way, that word is very often, when we talk about competencies, in Ukrainian, we talk about knowledge, skills, and attitudes. In English, we translate that into знання, вміння і ставлення. The problem is that the word ставлення in Ukrainian is not exactly the same thing as attitudes in English. I think you're meaning something a little bit different, because ставлення would be, of course, it's translated as a word in attitude, but it has a different subtext. So what do you mean when you talk about attitudes?
I think that you have to have a positive relation. And I mean a relation to your patient. That's the first attitude you have to have. But you also have to have a positive relation to yourself, to medicine as a society. You have to have a positive relation to your country. You have to have a positive relation to the beliefs of your patient. You must have some positive relation that the patient can be religious or non-religious. These relations that you have, also a positive attitude, a positive relation to your own continuing medical education. That's also part of the attitude. That's what I think. It is a relational dimension, attitude.
I'm listening to what you're saying about positive attitudes, and the stereotypical American, that you have something called a false smile. Yeah, all Americans are always smiling, and they're always asking you, "How are you?"
Yeah,
I'm not sure that that's what you mean. So
no.
When you talk about positive attitude, it doesn't mean that a doctor has to be constantly smiling. Certainly, I don't want my doctor to be constantly smiling, particularly when I'm coming in and looking for expert advice. So let's talk a little bit more about what you mean by attitude. You mentioned positive attitude to your country. Okay, I guess that's patriotism, but that's not necessarily something that's relevant to a patient. So what are we talking about?
In terms of positive relation to your country is that you accept the laws, for instance. Mm-hmm. But that you are interested in changing the law if you do not agree with it, that you take part in the political process. And the positive attitude towards your patient is not smiling, but is to have an empathy and to have a belief in what he says, for instance, that you want to understand when he says, my heart hurts. That you understand what the heart is for him. Is it the pump or is it the psyche? That is something which I call a positive attitude. That you try to understand why he is coming, what his needs are. And also, for instance, a relation that you need is you have to find out how much does the patient want to know? How much information does he need? Does he want? Does he want to help you make the decisions, or is he so confident that he makes everything what you decide? So these are attitudes towards the patient which are very important in primary health care, especially in the continuing service delivery to the patient, because he will come back after he was in the hospital, what he needs then. That's what I think is the attitude towards the patient.
I get the impression that what you're advocating is that every generalist doctor should be a little bit of a psychologist.
I would say that is absolutely correct, and it is clear to me. He has to understand what the patient means when he says something and what the reason are that he uses this word and not other words. I think he needs that, because psychosomatic is not only psychological reason of disease, but is also how does the patient cope with his disease. The general practitioner has to know there are different coping mechanisms in the patients, how they relate to the disease. And that's something that's psychological knowledge.
Okay. Well, we have certain practices in Ukraine that have been continuing over time. For example, even family members, I would say, that would come up and say, well, if you have sniffles, if you have any kind of a problem with, something that looks a little bit like the flu, what we're going to do is we're going to go to the doctor, or maybe not even go to the doctor, just go to the pharmacy, get some antibiotics, and everything is good, right? So
would be wrong. That would be wrong, because for a sniffle, you don't need antibiotics.
Well, you and I know that. You and I know that. But the reality is that everyone one of the major problems just recently was that the ministry has made it a requirement that you must have a prescription to get antibiotics, and obviously several of my babushka friends are up in arms because of the fact that they treat everything with antibiotics. I know. At the end of the day, if you're a generalist doctor and a patient comes to you and wants to treat everything with antibiotics, and your attitude is to make sure that the patient is happy, you have a positive attitude to the patient, then you're looking at it and saying, well, I know that the antibiotics are not good for you, but, go ahead and take the antibiotics.
No, because your attitude is not only towards the patient, but also towards medicine, towards evidence-based medicine. You have also a knowledge about what is good for the patient. And in this case, it is the task of the GP to say, in this case, we don't need antibiotics. On the contrary, they are even bad for you and for society because we produce resistance.
Understood, but the problem is that there's a clash between that. I mean, obviously, I'm being provocative in my questioning, and I think you understand that.
Yeah.
There's a clash between the positive attitude towards the patient, and the positive attitude towards medicine, right? And now the question is, which one is going to be the task of the generalist doctor, of the general practitioner? Which one is more important?
Well, I think it's not a one or not. It is both. You have to be positive to your knowledge, and you have positive to the patient. And it is your task to explain the patient, even if he goes to another doctor and if he gets the prescription. Even then, it is your task to be honest with you and honest with the patient. Because if you are honest with you, you are also honest with the patient, because you don't want to give him a drug that is a nuisance for him.
Well, we talk a lot about this idea of empathy, right? So, I mean, I'm continuing to be a little bit skeptical, because empathy is obviously something that you're talking about as being a positive attitude towards the patient. And that's effectively sort of a skill, I guess, that we can learn, is to be empathic. But the problem is that if you become too empathic, you become an agent of the patient rather than an agent of medicine, right? So how do you keep that balance between one and the other?
I think that's exactly the word you use, is the balance. You have to be a representative of medicine, but you also have to be a advocate of the patient. You have to understand both. The empathy is not something that is absolute. Actually, we may be able to talk about the skill of empathy, because it can be learned, empathy. It is not only a talent that you have or not have. Empathy is not the ultimate goal. It is a help to treat the patient, because you understand him better when you are empathetic, I think you say in English. Being empathetic is something, a talent and a skill that you have learned, and you have to find the balance. I think the word you used is very important, but the main thing is in the attitude that you have to be honest.
Okay.
You shouldn't play the doctor by giving an antibiotic. Then you play doctor. That's not honest.
How do we teach honest empathy?
Okay. Teaching attitudes, teaching empathy are two things. One is model, and the other thing is skills. To be empathetic has a lot to do with communication. How we ask questions, how we answer questions, how we give the patient time to talk, how we give him hints to continue. These are all empathic tips that can be learned. But on the other hand, it is also something that you learn during you in our country, for especially during your post-university specialty training, which lasts 5 years. It is not just a 1-year internatura. It is a 5-year post-university specialty training where you start treating patients under supervision with no responsibility, because there is always a chief resident. And after 5 years, at the end, you can treat patients with much less supervision and with a lot of responsibility. This is a continuum, and you always have a chief resident and a chief doctor who is doing ward rounds with you. And during this 5 years of time, you learn by the model of your chief resident, by the model of your chief doctor, you learn empathy, together with skills, together with knowledge. And that's the important thing of our post-university specialty training, which is lacking in post-Soviet countries.
Back that up for a second, if you don't mind. The Swiss trajectory of educating a doctor is how? You go through a university, which is a generalist university, then you go to medical school, and then you have 5 years of an equivalent of internatura. How long does this whole thing last?
You know, medical school and university is the same. A medical school in Switzerland is a combination of a school and a hospital. So in the first years, you start with physics and chemistry and everything. And in the second year, you continue with physiology, anatomy, and pathophysiology. And then start more and more the clinical teaching. And the clinical teaching during the 6 years of medical schools after the gymnasium, which is finished at about 19. After these 6 years of medical school, at least in the second year, already in many universities, even in the first year, you are exposed to doctors who practice medicine. You go in their cabinet and you look and you get taught what he is doing. And then in the third year, for instance, you go to the clinical skills lab where you do things on moulages. And in the next year, you go in a group teaching for clinical skills, and you do, for instance, heart auscultation, lung auscultation, liver, spleen palpation, looking in the ears, in the eyes, whatever. You do on each other. And the next year, you go to patients, because the medical school is within the university hospital. University hospital is not just a building where a hospital is. It is a campus where you have the medical school, the research, and the hospital. Because a teacher at the university in Switzerland and also in Germany, in all our countries, they are 3 things. They are doctors treating patients. They are teachers teaching students and interns and residents. And they are researchers doing basic research or clinical research. I exaggerate a little bit, but I say in Switzerland, every doctor is a teacher, and every medical teacher is also a practicing physician.
And a researcher.
And at the university, he is also a researcher.
We're going to have to figure out how we balance between those things as well, because that's a very difficult different balance to find. But let me get back to 1 second. We've gone through the trajectory of medical school, and then after the medical school, there's an additional 5 years, is what you're saying?
5 years, and you get the job as an assistant. We don't call them interns, we call them assistant. You go to a hospital and you are paid for the work you do. When a patient comes in, you go to the patient, you make the history, you make the physical examination, you think about what it could be, and then it is discussed with the chief resident. So, first of all, you are educated and you get experience. And at the beginning, you are supervised very closely. And you have no responsibility. Everything what you do has to be discussed with the superior. After 5 years, when you are almost certified specialist, you may treat the patient and only report to the chief resident or to the chief doctor. And you have a lot of responsibilities to get a consilium by a specialist, to prescribe a drug. And at the end, you can then enter private practice or becoming a hospital doctor. That's 5 years in the minimum. Narrow specialists have 6 years, 7 years. It depends on the specialty.
So to be a general practitioner, you're effectively saying it's 6 years of medical school plus 5 years of assistentura or internatura.
Yeah.
Effectively, that means that a doctor, a general practitioner, to be certified is going to be a minimum of 30 years old.
Right.
And then if you're looking for someone that's a specialist, it's probably going to be older than that. For example, surgeons, etc., are going to be 32, 33. That's when they really start their career.
Right. And that's possible because you are paid by the hospital, because you are treating patients, and the hospital is paid by the insurance for the treatment of this patient.
I was just going to say that sounds like a very, very expensive system of medical education of preparing doctors. But nevertheless, obviously very, very effective as well. Let me ask you this idea that you've repeated several times, and that is that doctors are all teachers, and that one of the aspects of being a doctor is a teacher. I think that one of the things that we find in Ukraine, particularly in specialists, not necessarily amongst general practitioners, but certainly in specialist doctors, that they hold their own skills to be sometimes a bit of a secret. In other words, there's this idea of, I'm a good surgeon and I'm not going to tell anybody else how I'm becoming a good surgeon, because then I'm going to have my own competition, right? And so it's always good to keep things to yourself a little bit. You're saying that the attitude in Switzerland and the attitude that you're promoting in medical education reform is different, that doctors have to be teachers. How do we change that attitude?
How to change it? That's quite difficult, I think. But the problem is that in your countries, the university is separate to the hospital. And I have seen countries, as in Mongolia, for instance, the professors at the university were not allowed to work in hospitals as treating physicians. The first thing is to combine the university with a hospital, to integrate education at bedside with theoretical teaching at university. I think as soon as one person is treating patients and education students and interns, that will change. But this change naturally needs a lot of slow, stepwise introduction. Therefore, I am told that I think your president would like to have a university hospital. I think that should not be done. You don't need a university hospital. You need a medical school according to American or Swiss models, which is combining what I said, combining teaching and skills teaching and models being a model. That is attitude showing.
Let me ask you clarification. How is that different from a university hospital or a university clinic?
What I think you would like to have is a hospital which called university hospital. But that's not a building. A university hospital is a campus. It has a lot of, it has a surgery department, it has a gynecological department. They have to be houses maybe, but they are all in the campus, and all the doctors working at the gynecology clinics are also teaching the students and the interns theoretically. They are not just in the hospital on the one side and the other person is teaching gynecology at the university. It is a combination.
Right. So what you're promoting is that every professor that is teaching theory should also be a practitioner, and every practitioner should also be teaching theory. So you're combining these two. Understood. And this is something that's very different from the Ukrainian model, where we have teaching of theory happening in the classroom, and then maybe during the internatura or maybe during the fifth year, university students are actually allowed to go into to see patients.
And this skills teaching is much too late and too short.
Let's go after one other thing, because you mentioned when you were talking about the role of a practitioner teacher, you also mentioned that this is someone that in a university environment, in a university hospital, should also be a researcher. Let's talk a little bit about research, because I find it very difficult to imagine how we're going to balance these three things. Yeah, because you've got, and as a matter of fact, it's four things, because usually for careers, what we see practitioners, we see teachers, we see researchers, and then there's a little bit of administrative work that also needs to be done. I mean, there's only 24 hours in a day and only 7 days in a week. How do I balance between all of these four functions?
First of all, if you get an academic career, you have to work a little bit more than somebody else. That's the first thing. That's understood. The second thing is, whenever you do practical work, you encounter problems that have not been solved. So if you are really an academic, you are so curious, why hasn't that been solved? That you always find questions that you can make research out of. And for that, you need, by your contract with the university and with the university hospital, you need, for instance, 1 day off a week to do research, or every year, 3 months off to do research. When I did my research at the university clinic, I always had, every year, I had 2 months off to do my research, which I had learned during a stay in the United States. I was able to go to the lab, to write a protocol, to implement the protocol, and then to write a paper about that. Mm-hmm. I had 2 months where I could only do research, but during that time, I always also followed the morning conference of our department. I followed the teaching hours, because during the postgraduate specialty training, you have, every week, you have lectures. Every week you have case presentations. Every morning you have short teaching sequences. So teaching is always integrated into everyday work. And that's the important thing, where you do teaching and clinical work together, and research is done in your free time, either by contract with your employer or in the evenings and during the weekend.
This is something that is controversial in Ukraine, because when we talk about the research requirement of academics, generally, I mean, we need to understand that the way that the compensation system is set up in Ukraine, the way that we are paid, is that we are paid to teach and do practical things, and then we have this sort of additional time that we are supposed to use for our research. Many times that's not enough, because what you're doing is you're concentrating on your teaching during the week, and there's really no time to do additional things that are research-based. I mean, there's 2 hours, perhaps maybe an hour and a half every day, and that's simply not enough to concentrate. And the idea of having 2 months off to do research is something that's very foreign. But at the same time, we are asked, or we are required to publish. And we are required to publish in international journals. We're required to publish in local journals, etc. So there is a requirement. There's all these discussions about Scopus and Web of Science and all of these things that are that you have to have your articles published in likely very expensive, actually, journals. And there's no compensation for that. I guess my question is that the reaction to that is that, look, why do we really need these people to be researchers? At the end of the day, if they're good teachers and they're good practitioners, we are providing the attitudes to the students that we need to be providing. Let research be done in the Academy of Sciences. That's what these people are done. That's what these people are there for. That's the model that we get from the old Soviet days. It actually is a model that was implemented in Germany 100 years ago under the Humboldt system. And frankly, maybe that's the way to do it, because what you're describing in the Swiss system is, frankly, a doctor is a practitioner, a teacher, a researcher, an administrator. Sometimes he actually has a family also. I mean, we'd like to have these people live.
Okay, here I have two remarks to do. The first is, if the requirement is such in your country, you have to change the requirement, period. You have to go to the ministries and say, don't teach us top down. You don't know how we work. You have to change the requirements. That's one thing. Because that's really because you lawmakers and those who make the orders, they are somewhere in offices and they do not talk to those who do the work. And that's a very important thing in Ukraine, that those who make the laws and the orders should more talking to those who really do the work and cooperate with them. That's one thing. The other thing is, doing research is not something that is done in an office. It is also done by seeing patients. As I said, you get the questions by seeing patients, and you get also something answers how to do the research. And the third thing is, not every good teacher is a good researcher. The discussions you have about who is a good teacher, why does he have a researcher, we have exactly the same discussions. And sometimes a good researcher, even if he is not a very good clinician, is selected, but then he has vice chief doctors, he has very good clinicians on his help, and sometimes we just select a very good clinician and we say he can have a lab, but he will have a chief of laboratory. He will do the research.
Okay.
You have to find these, it's like with the attitude and the knowledge, you have to find balances. It's the same in your life, you have to find a life balance.
Okay, so this is about the only way that I can see this actually being implemented is at a local level, where you have an autonomous university, an autonomous clinic, where decisions will be made on a local level rather than trying to be implemented top down. Okay, let's talk a little bit about your research, if you don't mind. You mentioned the fact that you had some time in the United States, that you were doing research while you were working as a career doctor. Your research is mathematical. Yes. It's pharmaceutical.
Because I was in general medicine, I was looking something that goes in all the specialties, that is not organ-based or some disease-based. So I choose clinical pharmacology, the study of drugs in the body. What does the body do with the drug? Which is pharmacokinetics and pharmacodynamics. And to do this, you need a lot of mathematical modeling, because you are modeling concentration of drugs in the blood and you are modeling effects of the drug in order to calculate the correct dose. And to do this, you need mathematical models that you try to adjust to the data. You should never adjust the data to the model. That's very, very, it's also, it's also in the mind. You have to adjust your model to the data, not the data to what you have in mind. And this was very interesting, because then as a general physician, I was able to use really rationally and correctly drugs. And I was able to try to dose the drugs according to the patient's height, weight, sex, gender, and body weight, etc., and kidney function and liver function. All these, I was able to talk with every specialty about the drugs. I was glad that I had chosen clinical pharmacology, although my real specialty was general medicine at bedside.
That's a fascinating combination, because quite frankly, clinical pharmacology is something that one would consider to be very, very specialist. And at the same time, you were, as a practitioner, you were very much a generalist. I think that makes you a very, very unique person. And I'm very pleased that you have been able to try to share some of that uniqueness. You are someone that within the Swiss-Ukrainian medical education project is someone that is running something called the peer groups, and you've been doing things with peer groups. I want to talk a little bit about that, because our discussion today has been about sort of general things and how we institute in a medical education format proper attitudes. We've tried to sort of balance between attitudes or rather competencies and skills. and knowledge. We've tried to talk about research and teaching and practitioners. All of these things come up, I would expect, in the peer groups. Tell me a little bit more about that.
Peer groups, in Switzerland, we call them quality circles. I call them peer groups in Tajikistan because I noticed that whenever they have a learning session, it was only one who talked, and that was the chief doctor. All the others didn't even dare to ask a question, because asking a question means that you don't know, and that's forbidden. So that was one thing. The other thing was changing the university, changing the curriculum is very difficult because that's a very inert system. Changing postgraduate education, specialty training, is very difficult because the ministry wants to be in charge of it. They want to get money out of these interns, and they want to say what has to be done and where are the jobs. But continuing education, doctors who work, who are practitioners, they want to learn for their daily practice. And in order to do that, we started with peer groups where only practitioners met twice a month for 2 hours to discuss a problem or a case presentation or a new guideline or some other things. And one of the practitioners was preparing it, another one was leading, mediating the peer group session, and we trained very many peer group moderators. We call them facilitators because they are facilitating the meeting and the discussion. And I think that's very important. It is based on modern adult learning theory. An adult wants, first of all, to be respected. He would like to ask a question if he doesn't know, and he would not like to be laughed at because he doesn't know. The other thing is he wants to say what he needs to know. Mm-hmm. It's like you had, I think, Повышение Qualificatia. Every 5 years they went to the center and some institution decided what has to be learned, and then it was an exam. And when you had the exam, everything was okay. That's not adult learning. Adults want to say what they need to learn because they have a problem encountered during their work. And in order to start to change continuing education that should be based on daily work, on daily need of the doctors, we started these peer groups. And very many peer groups, it was clear a success. It was the first time that doctors among themselves were teaching each other and were able to ask questions and to present problems they had without having a superior who, when they ask a question, they always say what's right. Yeah, that's very important for an adult who has a problem. And in addition, they learned how to look up in the literature the answer. What literature can help me to solve a question, to solve a problem that they encounter? I think that was a very important step for continuing education, continuing professional development, as it's called now. And it is based on laws of adult learning.
Let's just take a moment to try to figure out how a session of adult learning would work. Because, I mean, you've talked about the theory a little bit, about the fact that it's supposed to be a discussion, that it should be not necessarily a lecture, that it's going to be very different from the Podwyższenie Kwalifikacji method. It sounds to me from what you're saying is, it's something that comes from a movie, Alcoholics Anonymous, yeah? Alcoholics Anonymous, someone comes in and says, "Hi, my name's Mihайло and I'm an alcoholic," and everybody says, "Hi, Mihайло." I think that's not really what you're talking about, yeah? It's not that kind of a peer group. Describe what the sessions look like.
Very many sessions are case-based. A doctor presents a case that he encounters in his practice and he doesn't know what to do. For instance, he has a patient with a hypertension, he gives them drugs, he adds drugs, and the hypertension never goes down. Now, he doesn't exactly know how to proceed. He checked the kidney and the kidney was okay. Why does this patient always have a hypertension? He presents this, but he does not only present this case, or he presents this case and a specialist is welcomed and is asked to answer these questions, or he goes himself into the literature, into the internet, and tries what is a modern way to diagnose a non-responsive hypertension, and what is the modern way to proceed in order to change the medication so that the hypertension goes down. And during this case presentation, often even the patient comes in and he says what he feels, that he always has a headache in the morning and he takes the pills and it doesn't help. You know, in these, you have the case, you have the patient, and then you have the theory. And then is an open discussion and all the doctors are asked, did you encounter similar problems? What did you do? Whom did you ask? What did help? And at the end, the facilitator makes a summary, and he tries to give a take-home message that can be used.
It sounds like basically a repetition of concilium.
It is a repetition of concilium, maybe much broader naturally, because then very many differential diagnoses are exposed and so, but it is a concilium, yeah.
Okay.
It can be a concilium, it must not, but it can be used as a concilium, where everybody of the peer group is learning something. Because one of the doctors had this problem.
And this is something that you feel in your experience has been a way of doing adult learning and continuing education in a much more effective way than traditionally sort of coming in and saying, these are new treatments in a lecture. This is, sponsored by a particular pharmaceutical company, etc. And this is a more effective way of adult learning, is what you're saying.
Much more, because it is problem-centered, and not drug-centered or novelty-centered. It is on the problem.
Okay. Let me ask you, getting away completely from medical education for a moment, or rather, obviously something that is useful in medical education, but I'd like to hear your prognoses or your opinions on the current situation with respect to Ukraine becoming a candidate member for the European Union. Is that going to be something that's going to change the way that medical education, the medical profession, there's a lot of people that are very concerned about this, that, we become a candidate now, then we'll become a member and all the doctors will run away, meaning that they'll go find jobs in Germany and in Poland and that sort of thing. And that in fact, this is going to be the end of our own medical education sector because, frankly, all the students will also go and study somewhere in Europe. Is that really a fear in your opinion?
It can be a fear. You are right. I don't think it is one. Because European universities have numerus clausus, which means they have a certain amount of students they can accept, and all the others cannot study there. So it will be important that your universities will stay for Ukrainian students who want to study medicine, because they will not be able to study all abroad. Mm-hmm. And I think that is actually one very negative point in the educational system in post-Soviet countries, especially also in Kyrgyzstan, Tajikistan, Uzbekistan. They are doing universities for foreign students.
Same problem in Ukraine.
To earn money.
Yes.
And I tell you, that's something that should be forbidden from top down. You should educate your students in your places, with your patients, with your topic of diseases, and so that's very important. It should be a minority of foreign students, and the most students should be Ukrainian.
That's something that's very, very difficult to implement, because at the end of the day, we had, just before the full-scale invasion, we had up to, I think it was almost 70,000 foreign students primarily studying in medicine. Each of those students was bringing in, well, let's just say, just in tuition, about 100,000 hryvnia per student. So we're looking at billions of hryvnia per year coming into the Ukrainian economy. And for us to completely, sort of isolate the foreign students is probably not realistic. However, that means that the Ukrainian medical education system has become a business rather than becoming, in other words, it's the business of education rather than education as a means of.
That's one of the problems in your countries, that medical education is a means of income, and it's a means of income of the professors and not of the state. I suppose that most of this money doesn't go to the state and doesn't go to the society.
Well, actually, much of it does go to the society. This is something that we have to be clear on, that it is these are official payments. So in fact, they are improving the economic status of the cities in which the universities are in. But nevertheless, I agree with what you're saying, and I think that we all agree with what you're saying, that this idea of having separate faculties, for example, for foreign students and for Ukrainian students, means that the Ukrainian students very often don't get the kind of quality education that they should be getting. One of the things that we've heard today is that some very tangible things about how that education should be changed. I want to thank you, Renato, for joining us today for this conversation. I think that certainly I heard some things that were new today, and I've learned quite a bit from, I'd like to say my peer, but a little bit older peer, nevertheless.
Okay, thank you very much for having me here. It was a pleasure to meet you and to get, to know you. Thank you very much.
Thank you very much, Renato Ґалеацці, and thank you very much for being with us today.